Hi, everybody. We're now going to, I think, move very nicely from Kevin's presentation, which is very much on the level of policy and theory, to the efforts that we have been making in the last couple of years to apply some of these things in practice. I'll very, very quickly go over the background because Kevin has so well covered this already. But it really is a fact that long-term care homes are increasingly playing the role in our healthcare system of caring for the very, very frail and elderly population who will be expected to, for the most part, end their lives in the long-term care home. So they are very much becoming a hospice type of environment of sorts. Palliative care, as you know, is as much a philosophy as it is a unique set of interventions. And I think one of the things that all of you who work in long-term care know is the provision of really holistic, resident-centered, multifaceted care that we believe in palliative care is very much what resident-centered care is all about as well. So in that respect, Kevin's point about the synergy between some of the initiatives is well taken because the goal is quality of life. We began our program on the premise, though, that although long-term care homes do provide care to many, many dying residents, and in many cases do it well, many don't have formalized programs. And it was our experience when we looked around that the provision of end-of-life care was inconsistent, as Kevin said, without a lot of best practices, without formalized program guidelines to really help long-term care homes take on this goal more forcefully. So we applied to the Social Science and Humanities Research Council and were successful in getting a 5-year project which we call the Quality Palliative Care in Long-Term Care Alliance. And I think this is extremely unique for what we call a research project. It's not a traditional research project because we are working with 40 organizational partners, and those are partners like the Ontario Multi-Faith Council, the Alzheimer's Society, which are just examples of service delivery or clinical partners. Then we have a lot of knowledge transfer partners like the National Initiative of Care for the Elderly and Sherton, who are a co-sponsor, and many other organizational partners. We also have many researchers. We have more than 30 researchers, including Kevin. The colleagues he was referring to in Australia and England are part of our team, and we're really trying to bring some of the best practices that have been developing internationally down to a practice base within Canada and specifically Ontario. And we're working with 4 long-term care homes as our study sites, 2 in Thunder Bay and 1 in Milton and 1 in Burlington. So what are we trying to do? Our goals are to empower personal support workers to maximize their role in palliative and end-of-life care because they provide such a huge amount of that hands-on care. And we also feel that by working with them, we can help them be catalysts of organizational change. We have a 4-phase process of community capacity development that we're piloting. And this model, which I'll explain in a moment, is our effort to ensure that the kind of changes we introduce are sustainable and are really, rooted in the culture of the long-term care homes. And we do, at the end, want to have a toolkit of evidence-based best practices and interventions that can be shared. The changes that we will develop, in addition to empowering PSWs, we'll be working with the homes to develop palliative care teams that are well suited to the way they do business. I don't expect they'll look like palliative care teams in a specialty hospice palliative care setting, and very much wanting to strengthen the linkages between the long-term care homes and their community partners. I feel that long-term care homes have been operating very much in isolation from many of these other resources in the community that have a lot of opportunity to enhance the work that they're doing with residents and families. And then lastly, there's a real training component. We are working with many, many graduate students, and we're also very much wanting to engage the staff in the long-term care homes in understanding the research process that we're going through. So again, these kinds of skills are built in. I basically mentioned our activities, so I won't repeat them, and you can see how we're moving forward. And as I said, we have 4 cases, these 4 long-term care homes. One of our conceptual frameworks, and I'll just quickly look at it because I think this is a different way of approaching things than a lot of introduction of new practices, which Kevin referred to as shallow and sometimes not sustainable. Because we really want to start with the roots of what is going on in long-term care. We want to really have a vision for what palliative care is in the long-term care setting. We really want to have the staff themselves empowered to drive the changes and development. We know that it's going to be founded on collaboration, both within the home and between the home and the community partners. And we know we do have to pay attention to infrastructure. And by that I mean the staff, the resources, the equipment. And while it's always necessary, and we will be advocating for more resources, I did, for example, present a brief to the Federal Parliamentary Committee for Palliative and Compassionate Care a few weeks ago, emphasizing the need for some attention to really be turned to helping long-term care homes with the task of providing palliative care. In the short term, we're going to have to do the work within existing resources, so we're very anxious to look at how we can leverage what is being already done in a way to make it better. Once we have a real sense of what's going on, we work with the home to help them create their palliative care team and then start to grow the program. And when you look in the foliage of the tree, you'll see that it's a very multifaceted program, and I couldn't help but think when Kevin was speaking about all the domains of the gold standards in the United Kingdom, that many of those are mentioned there, because it is also not only clinical care, but also the education, the advocacy, the linkages within the home between the different disciplines, and the linkages within the community. The second framework we're using is the Canadian Hospice Palliative Care model of practice, and it's been our experience that it isn't well known in the long-term care sector, and I'll just break it down very quickly and encourage you to go to the Canadian Hospice Palliative Care website. But part of it looks at direct care to the resident in this case and the family. And when you look at the common issues, you'll see that those are really the common issues of really good, holistic, resident-centered care. So it's completely compatible. But in our environmental scan that we've done, well, there was recognition by the home staff of the importance of doing all these things. The reality really was that most of the emphasis was on disease management and physical care, and it was very difficult for them to address all of these other domains. And then across the top, the caregiving process, which again is the caregiving process that you would do in all care, was challenged by a lot of the difficulties that you would be very familiar with around communication and teamwork, and sometimes assessment skills. The organization is a very important part of the model of care, and there are certain resources that are important for providing palliative care. They can include things like education, but also certain equipment and medications to have immediate access to. And in our experience so far, we have found that as far as the functions, there really isn't a lot of explicit policy to guide the staff as they move forward in their work. This is another model from the CHPCA's norms, and what I think it brings to the table, although Kevin's right, it may not be directly applicable because it did come out of more of a cancer model, but if you think about the experience of a resident entering long-term care, the average length of stay is approximately 2 years. Now, I know there's huge variability there. Could be a couple of months, and we had a resident die recently in one of our homes who had been there 30 years. So I really understand that this 2 years is very hypothetical. But if you imagine the resident sort of entering the long-term care at the bottom left-hand corner of that diagram, where they talk about presentation, so that could be more like admission into long-term care. Rate 2 on the right, the death of the resident, you'll see that the idea is that palliative care should never be mutually exclusive to therapy to modify the disease, which in this case would maybe be restorative care. That the two things happen concurrently from admission to end of life. And it's really the emphasis that may change over time. And I liked Robert Buckman's very simple depiction of beginning, middle, and end. And at the beginning, probably most of the emphasis is on restorative care, and from a palliative perspective, probably introducing some advanced care planning and a lot more communication. In the middle, the goals of care begin to change to introduce some goals of care that are more consistent with the palliative approach. And then towards end of life, they really become more focused on relieving pain and symptom. And not to mention the bereavement piece that we are finding has not received very much attention for residents, staff, or families. Our timelines, very quickly, we're in year 2. We've done our environmental scans of the 4 homes to try and understand current practice, and we are now working with each home to develop their palliative care team and identify some of those initial interventions that they feel are important to help them move from where they are today to where they want to be in their vision. Each team will look a little bit different, and we're understanding that homes are unique, and we're going to study how things work out to try and extract some of the best experiences from each of the 4 homes. We then will go on to develop the program, evaluating all these interventions using the PDSA cycles, which you're very familiar with, getting the staff involved in doing that so that it is very much their program. And then, of course, at the end of the 5 years, evaluating the changes.